Hello, and welcome to CRPS Contender, my complex regional pain syndrome education channel. Today's video is You're Hot, Then You're Cold, and we will be taking another step down our journal journey as we discuss the paper Vasomotor Disturbances in Complex Regional Pain Syndrome, a review. This article was written by Dr. Gunnar Wasner from the Department of Neurology and Division of Neurological Pain Research and Therapy from the University Clinic of Schleswig-Holstein in Kiel, Germany. It was published in Pain Medicine in 2010. Let's read from the abstract. Complex regional pain syndromes are characterized by vascular disturbances primarily affecting the microcirculation in the distal part of the involved extremity. In the acute stage, inhibited sympathetic vasoconstriction and exaggerated neurogenic inflammation, driven by central and peripheral mechanisms, respectively, seem to be the major pathophysiological mechanisms inducing vasodilation. During the chronic course of the disease, as well as early in some patients, vasoconstriction dominates the clinical picture induced by changes in microcirculation itself, such as endothelial dysfunction or vascular hyperreactivity, whereas sympathetic vasoconstrictor activity returns and neurogenic inflammation is less severe. It can be suggested that the interaction between different mechanisms underlying vasomotor disturbances, as well as the severity of each single mechanism in the individual patient, have a great impact on the variety of the overall clinical picture in CRPS. Irrespective of the underlying pathophysiology, measurements of skin temperature differences between the affected and contralateral extremity can serve as a diagnostic tool in CRPS, in particular when sensitivity and specificity is increased by considering dynamic alterations in skin temperature asymmetries. In CRPS, primary small vessels are affected, leading to microvascular disturbances with an impact on microcirculation, skin temperature, and clinical appearance of the limb. Microcirculation usually means arterioles, capillaries, and venules. Skin level, vasodilation, as well as vasoconstriction can be found during different stages of the disease. There is increasing evidence that microvascular disturbances in CRPS are caused by multiple factors, including dysfunction of sympathetic outgoing signals, pain signals coming into the brain, and non-neural mechanisms such as endothelial dysfunction. Internal validation studies evaluating the sensitivity and specificity of clinical signs and symptoms revealed that vascular disturbances are strong and independent diagnostic factors. Let's first discuss the sympathetic nervous system. In CRPS, autonomic dysfunction with skin changes in blood flow, temperature, and sweating, as well as symptoms of sympathetically maintained pain, which is pain that can be alleviated by a nerve block of the outgoing sympathetic pathways to the disturbed extremity, suggests that the sympathetic nervous system plays a crucial role in the pathophysiology of CRPS. Let's talk a little bit about normal conditions. Sympathetic preganglionic neurons, which are the neurons that run from the central nervous system to the ganglia, which is a bundle of nerves, kind of think of it like a relay station, which is involved in the regulation of effector cells in somatic tissue, the actual like muscle contraction, are under central control originating in the hypothalamus. Sympathetic postganglionic vasoconstrictor neurons, which is after the relay station going out towards the end organ, release noradrenaline and other co-transmitters like neuropeptide Y and adenosine triphosphate, and are mainly under thermoregulatory and respiratory control. Under normal conditions, sympathetic activity does not interact with pain-receptive neurons in the peripheral nervous system. Now let's talk about the specifics of CRPS. Skin-level vascular abnormalities in the affected extremity, such as abnormal vasodilation and skin warming in the acute phase, and vasoconstriction in later stages, are characteristic symptoms of CRPS. Studies on skin blood flow and temperature demonstrated that the warmer affected extremity in the acute stage of the disease is due to a functional inhibition of the cutaneous sympathetic vasoconstrictor activity, leading to cutaneous vasodilation, meaning the blood vessels have difficulty contracting, so they stay extra large for longer than they ought to. Consistently, direct measures of norepinephrine levels, which is the primary sympathetic neurotransmitter which causes vasoconstriction, as well as working in your fight or flight response. Measures of norepinephrine levels show a reduction in the affected extremity, indicating a substantial decrease of transmitter release from postganglionic sympathetic vasoconstrictors fibers on the affected side. The loss of vasoconstrictor responses and increased skin temperature are unlikely to be explained as a consequence of a peripheral lesion. It seems reasonable to conclude that a profound central inhibition is the underlying mechanism of the disturbed sympathetic vasocongestion in the acute stage of CRPS. Excessive sweating of the affected extremity is often found in early CRPS, indicating an enhanced sympathetic sweat gland activity. This pattern of opposed regulation of decreased skin level vasoconstriction and increased sweat outflow indicates a centrally located thermoregulatory dysfunction in CRPS. Degenerations of small fiber sensory nerves have been demonstrated, which raises the possibility of additional peripheral involvement in autonomic disturbances. However, so far there is no evidence of degenerated sympathetic outgoing controls towards target organs. Alternatively, these functional deficits might be due to autoantibodies binding to the surface of peripheral autonomic neurons. 30 to 40% of CRPS patients have surface-binding autoantibodies against specific neuron receptors in the nervous system. Measurements of skin temperature and blood flow over time demonstrate a change according to the duration of CRPS. In more advanced stages of longer than 6 months, the number of patients increases in whom skin temperature and blood flow in the affected extremity are decreased. There is evidence that skin-level sympathetic vasoconstriction activity returns to standard levels with the duration of the disease. So initially, this vasoconstriction activity is decreased, but then it returns to standard as the disease continues its course. The initial functional inhibition of vasoconstrictor activity in the acute stage might have led to secondary vascular hyperreactivity, either by postjunctional changes, which is where the nerve meets the target organ, or in alterations to alpha adrenoreceptor sensitivity in the absence of structural damage to sympathetic fibers. Such hyperreactivity could lead to increased vasoconstriction and reduced skin temperature, even though sympathetic postganglionic neuron activity is reduced. Alpha adrenoreceptor density has been reported to be increased in patients with CRPS. Now, this is not discussed in this paper, but this paper is, again, almost 15 years old. There have been papers published since that show that there are autoantibodies in CRPS patients that target these alpha adrenoreceptors as well, which gives some conflicting information of upregulation while the body is still targeting them. Let's move on from the sympathetic efferents to the nociceptive afferents, which are pain signals coming into the brain. In addition to the efferent sympathetic innervation, afferent neurons can affect cutaneous blood flow. Activation and sensitization of C fibers elicit local swelling and reddening of the skin, as well as spreading flare. These sensations evoked by C fiber impulses are conveyed centrally to induce pain sensation and antidromically, which is going up the nerve and then going right back down to the target organ, releasing vasoactive neuropeptides and causing cutaneous vasodilation. The reddening, vasodilation, plasma extravasation, which is outside of the blood vessels, swelling, and pain are called neurogenic inflammation. Neurogenic inflammation might be involved in the generation of vasomotor changes in acute CRPS. Axon reflex vasodilation, which is again where it goes slightly up the nerve and then right back down to a branch of the nerve to cause an impulse, or hopping directly from one axon to the next if they're connected on the same dendrite. Axon reflex vasodilation was significantly increased in CRPS patients and provoked protein extravasation, which is again that fluid moving outside of the blood vessels into the interstitial space. Now let's discuss some non-neural mechanisms. In particular, in chronic CRPS, when cold-affected extremities in combination with trophic changes often dominate the clinical picture. Non-neurogenic vascular factors have been identified, which contribute to vasoconstriction in this stage of the disease. At 18 months of duration, acetylcholine-induced vasodilation was significantly reduced in affected extremities, whereas sodium nitroprusside-mediated vasodilation was intact, indicating endothelial dysfunction in chronic CRPS. Endothelial cells are the cells that make up most cavities of your body, including blood vessels. At 2.8 years of duration, reduced local concentrations of vasodilated endogenous nitric oxide were found in parallel with increases in the amounts of vasoconstrictive endothelin-1. As peripheral vasoconstriction results in tissue hypoxia, which is a lack of proper oxygen, and acidosis, which is too much acid, followed by an increased production of free radicals, which further induces endothelial damage. This process might induce a vicious cycle of impaired perfusion, leading to the dreaded dystrophic limbs in cold CRPS. How do all three of these different factors work together? As there is sufficient evidence that sympathetic efferents, nociceptive afferents, and non-neural vascular factors are all involved in vasomotor disturbances in CRPS, the question arises which interactions between these different mechanisms exist. In acute CRPS, it seems plausible that both inhibited sympathetic vasoconstrictor activity and the release of vasodilating neuropeptides from nociceptive afferents contribute to disturbed perfusion. Nociceptor activation and sensitization is inevitably linked with antidromic vasodilation. However, neurogenic inflammation alone cannot account for the huge vasodilation and the increase in skin temperature observed in acute CRPS, because intact sympathetic vasoconstrictor reflexes are well capable for overcoming even severe antidromic vasodilation. Therefore, decreased skin sympathetic vasoconstrictor activity must be present in acute CRPS. However, the fact that despite common symptoms and signs of the clinical pictures of CRPS, including vascular disturbances, vary significantly between affected individuals, indicates that the degree of involvement of sympathetic efferents and nociceptive afferents in acute CRPS is not uniform and differs between individuals. In chronic stages of CRPS, when the initially warm type turns into the cold type of the disease, multiple factors are involved, which may be mutually dependent. Normalization of sympathetic vasoconstrictor reflexes in the presence of vascular hyperreactivity leads to pronounced vasoconstriction. Due to disease-related endothelial dysfunction, vasorelaxation is disturbed, resulting in even more sustained vasoconstriction, triggering a vicious cycle of tissue hypoxia, acidosis, and production of free radicals. In very chronic cases with severe dystrophy, there is evidence for nerve fiber degeneration so that any neural release of vasodilating neuropeptides would be abolished. About 30% of patients suffer from primarily cold CRPS, with decreased skin temperature and perfusion from the onset of the disease. What is the diagnostic value of these vasomotor disturbances? Independent of the underlying pathophysiology and whether vasodilation or vasoconstriction is dominating the affected extremity, unilateral vascular disturbances may be of diagnostic value because they are typical clinical features in CRPS. The measure of skin temperature differences between affected and unaffected sides has been repeatedly suggested to be an important diagnostic test for CRPS, enhancing the validity of the diagnosis. However, one dilemma seems to be the poor intra- and inter-individually reproducibility of temperature asymmetries in CRPS when assessed at only one single point in time. This is due to the fact that asymmetries in skin temperature are not static, but change dynamically. Skin temperature asymmetries in several CRPS patients are below the cutoff value of 2 degrees Celsius under resting conditions. The most promising approach that can be applied in the clinical setting and considers these dynamic alterations of skin temperature asymmetries is continuous monitoring of cutaneous temperature for several hours by small temperature sensors. What is the final outlook on this paper? Multiple neural and non-neural mechanisms contribute to the development and maintenance of vasomotor disturbances in CRPS. Apart from identifying so far unknown factors that may also be involved, further investigation of the interaction between the different mechanisms and its impact on the overall clinical picture seems to be of utmost importance for better understanding and improved treatment strategies of this complex disease. It should be kept in mind that nearly all investigations have been described so far have dealt with vasomotor disturbances in the skin. However, it is well established that CRPS particularly affects also deeper tissues, and further studies need to go below the surface to investigate, such as on vasomotor function in muscle and bone, to further explain the mystery of CRPS. 2 more videos that I have on my channel that discuss vasomotor disturbances are on Coder's paper. Those are called Congested Capillaries and Microvessel Malfunction. You might look into those. Thank you so much for watching. If you like what I'm doing here, please like, comment, or subscribe to boost the algorithm engagement so that I can reach more people. If you would like to see this paper directly for yourself, I will link it in the description below, as well as some of my notes and access to the slides. If you'd like to contribute to my living expenses, my Patreon will also be listed below, and thank you very much to my loyal patron, Emily Malcontent. I hope you learned something today, and I hope to see you next time.